Perfect. Thanks, Marvin. So before I introduce Dr. Wilkin, just wanted to make a quick announcement. So I'll just read this statement. UCSD High Rounds is a venue where high-minded science is presented and shared. Opinions and debate about the science is encouraged and welcome. We welcome everyone to attend and participate, including those from pharma and industry. However, if you represent pharma or industry in some fashion, we ask that you refrain from making oral comments or chat comments, no matter how valid it may seem, because it can be construed by other attendees as being biased or manipulative. If there's any disagreement with the content of or how a slide was presented, we advise that you contact the speaker after the event to discuss offline. So with that said, we're very pleased to have Dr. Tim Wilkin, who's a professor of medicine and chief of the Division of Infectious Diseases and Global Public Health here at UCSD. He's a clinical trials researcher with a focus on prevention of HPV-related cancers in people with HIV. His work includes clinical trials to define the role of HPV vaccination in people with HIV and its utility for prevention of oropharyngeal cancer. He's conducting trials on optimizing cervical cancer screening in low and middle income countries. Dr. Wilkins has had a longstanding research and clinical expertise in the prevention of anal cancer in at-risk populations. His work is funded by the National Cancer Institute, NIAID, ACTG, and the AIDS Malignancy Consortium. And we are very happy to have him as our leader and also helping us out at the Owen Clinic with our anal dysplasia clinic. So thanks, Tim. Go ahead and you can take it away. I'll monitor your chat and
Great.
we'll kind of go from there.
Great. Welcome, everybody. I realized that I thought I put my disclosures down here, but I did not. So I do consulting for Merck, and I've done a little bit of consulting for SIGA Pharmaceuticals, just so you're aware. Oh, wait. There we go. All right. So we're going to talk first about emerging HIV treatments. We'll move on to a little bit about CAB rilpivirine, some new data, talk about HIV prevention, and then finish up with some, I think, really exciting data about new long-acting antiretroviral therapies that will be in large-scale clinical trials, I think, later this year in many cases. And just for the punchline, I think we have several options
Oye, si pedimos
emerge.
una cobijita, ¿nos dará?
Oh,
Pregunta,
sorry,
pregunta.
Paloma. Your Paloma's muted now. Okay,
I'm
so
sorry.
it's okay. We're going to have, I think, several options for twice yearly injectable ART complete regimens, I would say, within the next few years. So that's pretty exciting. All right. So first, Artistry 1. I believe this is the Artistry study that we've participated in at ADRC, led by Tom Martin as a site. So this was looking at bictegravir lenacapavir. And so this was a switch study, but in contrast to most switch studies, which are generally enrolling people that have never failed and are doing quite well on, say, Biktarvy, this study is looking at people that were on a complex ART regimen. They just defined that as a multiple pills. And so many of them, you can see on the left, many of them had a history of resistance and in some cases, multi-class resistance. It was generally an older population. And the median number of pills was 3 per day, and about 40% were on twice daily dosing, so quite complicated regimens. And so the design was fairly simple. They just were randomized to either continue on their complex ART regimen or switch to this once daily tablet of bictegravir and lenacapavir. And what they found was that the primary outcome, this is the snapshot analysis, just so people are aware, this is the general way that FDA wants antiretroviral studies to be organized. So you have 3 parameters that are looked at between both groups. One is the proportion that have a viral load assessed and are less than 50 copies per mil. There's the group on the left that are assessed and have a viral load over 50 copies per mil. And then you have those with no virologic data. And so, depending on whether it's a naive study or a switch study, one of these two parameters on the left and in the middle are the primary endpoint. Um, I'll just say that there's a little bit of controversy in the ACTG. We tend not to use this endpoint because, as we know from clinical practice, there's a lot of noise at 50 to 200 copies that really means nothing. Some people would suggest the 200 copies is a kind of a better outcome. But either way, in this case, it was the primary endpoint was the number with detectable viral load. And you can see that the point estimate very slightly favored bictegravir and lenacapavir, but clearly excluded the non-inferiority margin, suggesting that this one pill combination once a day is non-inferior to the more complex ART regimen. Um, so there was no treatment emergent resistance in either arm, and the CD4 counts looked great. Um, and there was a couple of people that had some detectable viremia in the BIC-LEN, but were resuppressed on a prior treatment. So basically, everyone did quite well, and this is a really nice option. And the other thing that I think this really implies about the integrase and the capsid inhibitor, as we'll learn later, there's a long-acting integrase that every 6 months that's being developed, and there's a couple capsid inhibitors. So this combination of long-acting integrase, long-acting capsid inhibitor being able to suppress, maintain biosuppression is critical because there'll be long-acting regimens with that combination with those two drug classes. They also looked at lipids, and the lipid outcomes were better with bictegravir and lenacapavir, I think primarily driven by people that were on protease inhibitors and the complex ART regimen. And then and patient-reported outcomes were better in BIC-LEN. Not surprising, it was much simpler for people. And so there was also Artistry 2, which was a switch study, I think kind of less groundbreaking in that it was a randomization between bictegravir FTC TAF, staying on that, or switching to BIC-LEN. And population a bit different. These were, I believe they didn't have a history of resistance at all, younger population. But again, you can see the same snapshot algorithm and really the same conclusion that this bictegravir lenacapavir was not inferior to bictegravir FTC TAF. I guess I would say that this is important just because we would consider bictegravir FTC TAF, if we were to have a single standard of care, that would probably be the closest. So really our go-to regimen, and this performed quite similarly. And again, the CD4 counts were quite stable. There was no change in, no difference in weight or BMI between the groups. And there were, again, a few people that had low-level viremia in the BIC-LEN, but they were generally resuppressed, sometimes with changing regimens. So again, good outcomes. Okay. So the next one is another two-drug once daily regimen. This is interesting in that it does not have integrase inhibitors, so it's a combination of doravirine and islatravir. And I think Dan mentioned this last week. Islatravir had the history of, at higher doses that they use for kind of weekly and monthly dosing, it was associated with the decrease in lymphocyte count. And so they figured that out, and they have the right dosing, and that doesn't happen in the studies now. But this again was this study actually is not a switch study. It's a first use of doravirine islatravir, so a naive study. And so it was a double-blind, active-controlled, randomized phase 3 non-inferiority study. So they enrolled people with a viral load of at least 500 copies per mil. no prior ART following diagnosis. So that means they could have received PrEP, I suppose, in the past. And they could not have had resistance to doravirine or NRTI-specific mutations, and obviously could not have hepatitis B infection. And so they were stratified by HIV RNA and CD4 cell count. So importantly, there were no CD4 cell count and viral load criteria. And so they had about 270 in both groups. Um, they did look at those with the viral load. They did have a futility analysis that I don't think ended up mattering for anything, but the primary endpoint was those achieving viral loads less than 50 copies per mil. So, and then of course the standard secondary endpoints that we see in these trials. So a younger population, as we would expect, is those newly diagnosed. Pretty good representation of women, 25%, 60% non-white, 40% Hispanic. Importantly, they had about 20, roughly 20% with a CD4 count less than 200. And they had a pretty good amount of people with a viral load over 100,000, over a third, and about 10% over 500,000. This is an international study, so they did have about half type, subtype B, and these other type C and non-B or C. And they had pretty good completion over 90% in both arms at week 48. And so the primary endpoint, again, for the snapshot analysis for these naive studies, the primary endpoint is the proportion that have a viral load at week 48 that is less than 50 copies per mil. And you can see the point estimate was quite similar, not between the two groups. Very low levels of HIV RNA over 50 copies per mil, and just a relatively small number that were not available for follow-up. So they concluded this was non-inferior to bictegravir FTC TAF at week 48, which is a great result. And then I wanted to show, I have another slide about the baseline CD4 and viral load, which I think is also impressive. There were a couple treatment emergent resistance in the doravirine and islatravir that had high level viral load detected at failure, and with emergence of resistance to doravirine. Both of them had really enormously high viral loads at baseline of well over 1 million copies. There was two serious treatment-related AEs in the doravirine and islatravir arm, one with what looks like or both with allergic reactions or drug-induced liver injury. But otherwise, the similar rates of adverse events between the groups. So this is looking at different subgroups in the analysis. The ones I wanted to draw your attention to were those with the baseline CD4 count less than 200. And you can see what's impressive to me is that the suppression rate, it's a smallish group around 54, but the suppression rate in the doravirine and islatravir group was over 90%. I think typically what you see in these analyses is what you see with bictegravir FTC TAF, where you start to see fall off in efficacy, but it's similar between the comparator groups. Here you see that in all of these groups, it's very high efficacy, whether over 100,000 copies at baseline or even over 500,000 copies at baseline. And you can see it seems like the efficacy is the same regardless of subtype. Okay. And then accompanying this is doravirine islatravir, a switch study from enrolled people on bictegravir FTC TAF and randomized them to either switch to doravirine islatravir or to be maintained on bictegravir FTC TAF. And then just skipping ahead, about 20% women, mostly white, 20% Hispanic. People had been on ART for a median of 3.5 years. And CD4 count, as we would expect, was quite high for a switch study. And what they found was that they looked at, in this analysis, it was week 96 outcomes. And then looking at those with viral load over 50 copies per mil, you can see that it was very low in both groups and non-inferior for the dravir/islatravir. And then the proportion that were less than 50 copies or less than 200 copies at week 96 was quite high in both groups. So there was a few people that discontinued for lack of efficacy, and for in the dravir/islatravir group, where that was not seen in the bictegravir FTC TAF. No difference in CD4 or lymphocyte counts through week 96. So met the definition of non-inferiority. I think, because of the NNRTI class, I think the possibility of resistance is there for the dravir/islatravir, where it's generally not an issue with the bictegravir FTC TAF. They did not see any clinical HPV reactivation. There were a few cases of low-level HPV viremia, but that was not accompanied with actual detection of hepatitis B surface antigen or elevated transaminases. However, there were 4 cases of acute HPV, hepatitis B. So these were people that were both negative to core and surface antibodies. And I think this is really quite important, that there's no difference in weight change at week 96. So this and other studies, have suggested that this concept of switching off of integrase inhibitors to doravirine, really does not lead to differences in weight, and switching off of TAF does not lead to differences in weight. So to me, this suggests that integrase inhibitors, aren't associated with weight gain. Maybe that's a bit controversial, but study after study is kind of coming to the same conclusion. This also highlights the critical importance with these novel regimens that are not active against HBV, or novel PrEP regimens that are not active against HBV. The critical importance of assessing for immunity to hepatitis B and vaccinating people appropriately, and if they don't respond to the standard vaccination, to use Heplisav, which has much better immunogenicity. Okay. So this is another long-acting regimen. That is once weekly islatravir and lenacapavir. So this is a pretty interesting approach. It's the only once weekly regimen that we have, or the only one that I'm aware of that's like in late stage development. So they presented results from the study before. So this is presenting some data from the extension phase. So this was a switch study. So it enrolled people that were virally suppressed for at least 6 months on bictegravir FTC TAF, no history of virologic failure, and no hepatitis B. And so the primary endpoint was at week 24, which they've already presented. And this analysis was looking at the week 96 outcomes, change in CD4 cell counts, and change in BMI and body weight. So what they found was that the people who switched at baseline at week 96, there was no one that had a viral load that was detectable. It's a smaller study, high viral suppression rates, less than 50. And then, as you might expect, after 2 years, there were some people without data available. And so all the people that had been suppressed really maintained suppression, suggesting that this is, a durable virologic suppression. At week 48, those on bictegravir were given the option to switch to weekly islatravir lenacapavir. And again, no one with detectable HIV viremia, all but one person with a viral load assessed and undetectable, and then just one person whose data was not available. So great results for this. Um, so for this part, artistry wanted to show that this bictegravir lenacapavir was not inferior to compare continuing baseline bictegravir FTC TAF, and I think more importantly, was a nice option for people on more complicated ART regimens. I will say that, obviously, if you're switching someone, you would have to be assured that they had not received lenacapavir before, and that they did not have resistance to bictegravir. And if that's the case, then that would be a good option to simplify their HIV regimens once available. And then the doravirine islatravir has good data to be used as first-line ART as compared to bictegravir FTC TAF. And I thought that was, I can't remember if that's actually been FDA approved or if that's happening soon. I think I'm kind of curious about is who would one use this on over bictegravir FTC TAF. I suppose if you were, or as opposed to dolutegravir 3TC. So I think that's going to be interesting to see how and if this combination is actually taken up and who would one consider for this two-drug regimen. And I think importantly, it had really good data for those with very initiating ART at very low CD4 counts and those even with higher viral loads. And this weekly islatravir lenacapavir, good data, durable suppression through week 96. So I think that will be an interesting option. I'm not really sure. This study was quite small, so I think they would have to have bigger studies to really be able to get an indication, but it does look promising. And I think for the broader group of investigators as well, I think what's interesting about the once weekly islatravir lenacapavir is we don't really have much adherence data or adherence strategies to support weekly dosing. And I think one thing that I've heard discussed is, would this be an interesting regimen to combine with for directly observed therapy, say combined with if you had people in a contingency management program for stimulant use, could you combine that with observed oral dosing of islatravir lenacapavir as a strategy in that particular population of interest? So I think interesting to think about how we move beyond daily pill taking and supporting adherence and how we support it for these long-acting regimens. Okay, so there was some data on cabotegravir rilpivirine that I just want to run through quickly. There was a study that looked at outcomes of switching from oral ART to long-acting injectable long-acting cab rilpivirine as soon as the viral load was less than 50. And not surprisingly, the outcomes were quite good. There were a few abstracts that looked at switching to long-acting cab rilpivirine while there was ongoing viremia. And they found that the outcomes, the number of people with confirmed virologic failure was very low in all the groups, whether they were undetectable when they switched or whether they had viremia. However, the low-level viremia, so 50 to 200, 300 copies, was more common when initiating with viremia. So suggesting that there may need to be additional monitoring, or they may be at higher risk for relapse in the future. But supportive data, I would say. There was, I think Dan mentioned this last week, there was a very small randomized clinical trial of 45 people that initiated, that were on oral ART, obviously not adherent, and therefore had ongoing viremia or suboptimal adherence. And they were randomized to either long-acting cab or continuing the oral ART. And they found a statistically significant difference with 72% being achieving undetectable viral load in the long-acting cab rilpivirine group, as opposed to 40% in the continued ART group. However, I would not say this is a very robust sample size, but it is supportive data in populations with adherence challenging to just initiating the long-acting regimen from the start. A large study from the OPERA cohort suggested that BMI was not related to viral failure, presumably because people are injecting the cabrolpivirine with the proper needle length to make sure it's intramuscular. And one that I thought was kind of interesting or provocative was that low-level viremia was more common on long-acting cabrolpivirine and those receiving every 2-month dosing as opposed to monthly dosing, and that they did relate it to lower cabotegravir troughs, suggesting that perhaps the cabotegravir dose may not be optimal for some people and they might need higher doses. They did not present any data on higher doses or kind of how one might achieve that, but I think definitely an interesting finding. Okay, I found this disturbing. So, if we have any resistance experts, I think this was actually discussed briefly in Dr. Sundquist's Medicine Ground Round lecture on Wednesday. So, these are about non-canonical mutations with dolutegravir. And so, like several terms that kind of come into vogue. This one is coming into vogue. And so I looked up the definition to make sure I understood it. And what it means is non-canonical means just non-traditional. So if you're looking at integrase, the traditional mutations would be in the integrase gene and affect the binding sites of where the integrase inhibitor binds. So these non-canonical mutations are mutations that are seen in completely different genes affecting different proteins or enzymes, and so just not directly associated with the mechanism of action to our knowledge. And so there's a series of abstracts that found that in the setting of failure with dolutegravir 3-TC-TDF, that there were these accumulation of mutations in the envelope gene. And so several studies have found it. And then there was also some in vitro studies that generated resistance to raltegravir or dolutegravir. So resistance was what you expected. There were mutations that emerged in the integrase gene. However, when they did the same experiments with dolutegravir, they got first these resistance or mutations in the envelope gene, followed by a nucleocapsid, and then followed by integrase. So I think this is happening. It's not very common, but I think I would expect that we'll see future studies that really describe the epidemiology of this and the risk factors for this. I couldn't tell from all these posters if it was just really related to people who had a prior history of NRTI resistance and then, developed this, or whether this could start with this first use of dolutegravir 3-TC TDF. I also don't know. I don't think any of this was really from US settings. So I don't know that this has been described, these similar mutations with bictegravir or dolutegravir-based regimens in the US. But I think definitely something that we should be on the lookout for people that have resistance or have virologic failure on these integrase inhibitors, seem to be taking it and don't have these integrase mutations. I don't know if anybody knows. I would assume that you would be able to pick up this resistance if you did a phenotype, but I don't know that for sure. But I guess that would be one strategy if you were suspecting it.
Tim,
Yeah.
Susan asked here, has anyone described any clinical implications or potential implications of the non-canonical mutations with dolutegravir?
Well, I would say that they found this in people that had virologic failure. So they had ongoing viremia. So I would say that, yes, it had clinical implications. I don't know if they also did drug levels to make sure people were also taking dolutegravir at the time. I think there's more data that needs to support this, but this, I'm sure, will be an area of active investigation.
Yeah. And just going back one, I think topic right before, Aaron was asking, any BMI data correlating to the lower cab troughs?
Um, in this last study, I don't think it was related to BMI. I'd have to double check the poster, but the only thing that they saw was it was related to the Q2 month dosing,
Right,
and obviously associated with the low level viremia.
right. Okay, thanks.
Okay, all right. Oh, there's my disclosures. Put it on the wrong slide. Um, Okay, HIV prevention. So this is the Prevenir study. So this was a large clinical trial, but it wasn't a it wasn't a randomized clinical trial. So basically, people were able to choose daily or on-demand PrEP, and they could switch strategies over time. And so they were had a structured follow-up with HIV testing and creatinine assessment. Um, and it's been going on for years. So the people that were enrolled were HIV negative adults at high risk of HIV infection. Um, and again, they could choose between these regimens, and this has been going on for 8 years. So they wanted to show that overall that they were able to have a decrease in new HIV diagnosis. I think on a population level in Paris from 2516 to 2324. And then they also looked at these secondary outcomes. So what they found was that people, you know, some people use daily prep all the time. Some people use on demand all the time. And then, not a small portion would switch between the strategies. And the discontinuation rate, whether they chose daily or on demand or the switch was pretty similar. Um, this confused me for a minute, so I had to reread it. So they had a very low HIV incidence overall. So this was 0.99 per 1,000 patient years. Originally, I was thinking it as 100 patient years. So this is, 0.1% per year um, that acquired HIV. And it was fairly consistent across the PrEP use. So while these look nominally different between daily and on demand, the numbers are actually so low that they're really not at all statistically different. And not unexpectedly, the TFFTC was well tolerated, and overall, and there was interestingly an increased risk of GI adverse events with on demand versus daily prep. I guess it's really just the initiation or the double dosing of the TDF FTC that was, I suppose, leading to the GI adverse events. And then when they looked at this was overall like the number of diagnoses in the Paris region. What they found was for French-born MSM, they had a population level decrease in HIV incidence. However, this was offset by MSM that were born abroad having a markedly increased number of cases, as well as among transgender women, really an increase. And so what I think this, and so overall, did not see a population level effect. And so I would imagine that this is really completely explained by who's able to engage and access PrEP care in the region. And so it just underscores all our efforts, within the division and elsewhere to really bring the benefits of HIV pre-exposure prophylaxis to broader populations and more vulnerable and marginalized populations.
Susan asked quickly, were there any subtype differences in the French-born versus born
Oh, I
abroad
mean,
MSM?
It's a PrEP
I
study.
Oh, got it.
yeah, but
just
I mean, I
correct.
guess they would. Oh, well, I mean, I guess one. I don't know if this was what you're getting at, Susan, but the way this is presented, it implies that they acquired HIV in the area,
In
but that
France.
might not be that might not
Yeah.
actually be the case. And so
I
if
was
this
wondering
were,
if it was acquired abroad, but I assume it was acquired in France.
yeah, I guess it's a great point. I don't know if they sorted that out, but the subtype would be an example of how they could, or using molecular epi techniques to see if there are, kind of linked diagnose or linked strains in the area. I don't know if they've
Great
done that.
idea. Yeah.
Yeah. But I would say, unless they didn't separate transgender women by, French born or not, but, clearly one would expect that the reason for that increase in cases is because of access and engagement and care. Okay, there was some additional data on the Purpose 1, Purpose 2 study designs. So Purpose 1 was a study in cisgender women comparing between PrEP study comparing between injectable lenacapavir, FTC TAP, and FTC TDF. And then at the end of this study, they were able to go to an open label extension. Similarly, Purpose 2, cisgender men, transgender men, and gender non-binary people compared lenacapavir versus FTC TDF, and then again an open label extension. So for Purpose 1, again in cisgender women, the spectacular results of no HIV infections compared to a pretty significant rate in those receiving oral FTC TAF or oral FTC TDF. So what they've, at the end of the double blind phase, so an additional amount of follow-up, they did have two women that acquired HIV that were receiving sub-Q lenacapavir and continued acquisitions and those receiving the tenofovir-based regimens. So overall, there were 77 infections in the oral PrEP arms and 2 in the lenacapavir arms. So the 2 that were that acquired HIV in the lenacapavir, one had very low levels of HIV RNA. So this Levi syndrome or Levi acquisition, where you have, I can't remember what it stands for, but you have this drawn out HIV infection where instead of you having huge bursts of viremia, you have this very slow increase in HIV viremia and that's observed. And so this person received all the lenacapavir injections on time, and the PK concentrations were within range. So this is viewed as a failure of that strategy. However, the other participant had discontinued lenacapavir for over a year and developed resistance while on oral PrEP. So suggesting that not really related to a failure of lenacapavir. And in Purpose 2, there were at the overall 3 people that acquired HIV in the lenacapavir arm, and the cases had been presented before. There was just one additional case who developed HIV RNA and had huge bursts of viremia. And the lenacapavir injections were on time, and the PK concentrations were within range. I would assume that there must be resistance to lenacapavir that explains why there was such a huge amount of viremia, but I don't believe that data was presented. So overall, great long-term results with lenacapavir supporting its use. So sorry, they do have this. So the resistance mutations in the so in the 5 infections in people on lenacapavir, resistance was identified in 4 of the cases, and not in one of them. And then there were really limited numbers of resistance in the FTC TAP, FTC TDF arms, and presumably that's because people were not adherent, so there wasn't enough drug around for resistance to emerge in the setting of suboptimal drug levels. Okay.
Uh,
So yeah.
Tim, so Susan, quick question. I assume that they have done highly sensitive HIV RNA testing to confirm that the one Levi-like participant was not acutely HIV infected at baseline. Do you know that or not?
Yeah, they went back and have tested all of viral loads to my knowledge.
Okay,
Yeah.
thanks.
So the Prevnar study showed that, among the French-born MSM, that they did achieve this kind of population decrease and reduction in HIV diagnosis. But however, in other groups, there really were not that same reductions. We have the continued efficacy of lenacapavir in the Purpose 1 and Purpose 2 studies, and that the new HIV infections were quite rare and generally associated with resistance to lenacapavir.
Yeah,
Okay.
sorry to close
Yeah.
out the last slide. Sorry, Dave Grillotti had mentioned it's interesting that so for Prevenir that 2023 to 2024 rates for the two MSM groups actually equalized, suggesting there's a population in both groups that are difficult to engage with PrEP.
Yeah, I wasn't sure if this is like an equity argument or if you're kind of just like kind of there's one group, there was no absolute numbers of people with HIV or what the kind of proportion of each sample, I guess, in the whole sample. But if you bring a bunch of people with a lower HIV rate into a community with a higher background HIV rate, um, wouldn't you potentially see like there's just a kind of equalization of the HIV rates if they're hanging out together?
Um, yeah. I mean, so essentially, the assuming that the population denominator is the same in both groups, which I don't at both time points, I don't know. But assuming it's the same, the there was no reduction in the number of cases overall. So the y-axis is the number of absolute cases. So you got about a reduction of like 450 cases in French-born
Hmm.
MSM, but that was offset by another 350 cases in foreign-born MSM and another, 50 cases in transgender women. So it really negated the population level effect. So yeah, I mean, I don't know that they said specifically, but it's, really, I would assume it's because of poor access to PrEP. However, we did discuss the possibility that if people had acquired HIV abroad and then immigrated to the area and then access testing, that could explain why some of this as well.
Gotcha.
Yeah.
Yep. And just time check 8:43. So FYI.
Okay. All right. So some investigational HIV prevention, just to kind of tell you what's coming in the future. This is another NRTTI. So it's a derivative of islatravir, and it's an even longer half-life, which, islatravir would last forever. So I find this kind of interesting that it's even longer half-life. But they think that the reason that they're developing this is that they believe that this, because of the way it's optimized, it will overcome the decrease in lymphocyte counts and allow for monthly dosing. So what they're planning to do is monthly HIV PrEP studies. And so this is a PK analysis, but basically it was to optimize the monthly dose. And so what they settled on is this 11 milligram monthly dose, which is, stunning to think about a tiny amount of medication that would last and provide protection for that long. But what is incredible is that regardless of dose, there's protection almost instantly an hour after the initial dose. And the trough, whether 31 days or more importantly, if you miss the monthly dose and come a week late, still has target drug concentrations after 38 days. So they're looked in other special populations in people who are pregnant, and there were like many drugs, there was lower exposure in people who are pregnant, but still expected efficacy or drug concentrations associated with efficacy. And as well, adolescents that were, similar predicted effective drug concentrations. And so they have expressive 10 and 11 underway. We are not part of those studies, but really quite an interesting option, and certainly um, easier to implement out of clinical settings, a monthly oral dosing, directly observed video therapy, lots of options for how this might be implemented. Interesting strategy. Looking forward to those results. So some early phase investigational HIV treatments. We talked about this last week with Dan. This was the study of cabotegravir given with a long-acting uh, monoclonal antibody or broadly neutralizing antibody. This is N6LS. And so this study randomized between a sub-Q version, an IM version, or continuing the standard ART. Notably, people had to have phenotypic sensitivity to the BNAB. So again, the FDA snapshot, I mean, pretty good results with the IV formulation, although I'll draw your attention to those with detectable viremia. I think in all the groups it was kind of high, but 10% and 6% for a switch study, I think is kind of high. And so there were failures in these arms receiving the cabotegravir and the BNAB, including people with integrase resistance. So, I mean, I personally don't see how this is going to go anywhere. I mean, myself, considering the drugs we're about to discuss, but interesting result. So one of the drugs is a long-acting integrase inhibitor from Gilead. So this is just some antiviral activity, which looks great at various doses through day 11, very similar to other integrase inhibitors over a similar time period. This is monotherapy. And then the concentrations, this is in people without HIV, really long concentrations. You can see about here 6 months. So really good supported PK data for possibly every 6-month dosing. So that's quite exciting. And so they're anticipating to begin studies this year. Another integrase inhibitor from this long-acting integrase inhibitor from ViiV, I think people are very excited about because it's at least in vitro active against highly resist or isolates that are resistant to dolutegravir. So this is again just PK profiling, but basically supports twice yearly dosing. So we now have 2 injectable integrase inhibitors that are predicted to be useful in twice yearly dosing. So now remember, we also have a injectable lenacapavir that's twice yearly dosing. So this is a long-acting injectable capsid inhibitor from ViiV. Again, this is PK studies, but really very long dosing. And it's, again, every 6-month dosing, and they're also beginning studies. So you have a Gilead capsid inhibitor and long-acting integrase, and you have a ViiV capsid inhibitor and long-acting integrase. So I would say, we're going to see studies with those every 6-month injectables from both of those companies starting up. And, if we would expect it would work based on the bictegravir lenacapavir study that integrase and a capsid inhibitor combined should control HIV. All right, just a little bit about hepatitis B. I don't know if Miley or Laura were co-author on this, but this was from the CNIX looking at HBV reactivation on a tenofovir-sparing regimen. So a very clinically relevant study. So they were looking at people that had either HPV reactivation or infection. And then they were looking at people that were on both tenofovir sparing regimens, but still containing 3TC or just non-HPV active regimens as well. And you can see the characteristics over here. So they had a cohort of people that had had prior HPV infection, a cohort that was naive to HPV, and then a cohort that did not have had unknown HPV status. So that's a little disturbing to have that degree in clinical care that don't have unknown HPV status. But anyway, that's what they found. And so the rates of reactivation of HPV were quite low in those that had prior HPV infection. So two people out of you can see the numbers there, the portion of far less than 1%. There were more commonly, you saw some HPV infection in people that had not had hepatitis B before, and similarly in those with HPV unknown status. So overall, it was the rates of this reactivation infection were quite low in the cohort, and the strongest predictors that they identified were low CD4 counts at the time of switch, or and then in certain racial groups, Black and Asians. And so I think there's additional studies that are needed to understand the significance of this reactivation and how you monitor for it, and ideally how you prevent it with vaccination and some other things. And that's it. So we can stop for any questions. I can stop share.
Perfect. Well, great.
So again, like I said at the beginning, I think what's really emerging from this is we're going to have studies of twice yearly injectable ART, and we're going to have probably a couple different options. So hopefully we'll be able to access some of those studies in the AVRC, because I think people would love it. So anything else?
Let's see. We'll go ahead and open it up. See if anyone wants to unmute, ask a question.
Then thank you, Dr. Solms, our guest doctor from Los Angeles, the Levi long-acting early viral inhibition syndrome. So this is where you get sort of the different slower HB or HIV acquisition than what we are expecting. Okay.
It is quiet. Must be a perfect presentation then.
Oh, we know that's not true from last week, right?
Great review.
Yeah, let me just pose one question then. So, crystal ball, looking in the future, what do you anticipate most people are going to switch to injectable every 6 months, oral? What percentage, if I were to put you, have you put your crystal ball, what do you think?
Well, I've really been thinking a lot about our presenter from Washington a few weeks ago, like the public health, like economics point of this. I just don't know how it's going to be sustained once we do have dolutegravir 3TC that's generic and basically costs nothing if that emerges. Like, how are we going to justify spending $30,000, or I don't know how much it's going to be, on these regimens for many people? I mean, for me, I think the exciting thing, and if we're concerned about ending the HIV epidemic and taking a public health view, is how do we apply these therapies to the populations that need it most? So people who use substances, people who are marginally housed, people, that are having adherence challenges. I think that's what we really need to advocate for, and hopefully do studies and supportive work, formative work to figure out how best to implement those strategies.
Susan, do you have a comment?
Yeah, I was just going to also I agree with Tim. I was going to also make the comment that there are huge disparities by state in terms of what's covered by ADAP. And that will just continue to drive a wedge between sort of groups of individuals who have access to these long-acting agents.
Yeah, I think my concern is the with the injectables is who's gonna the bigger clinics are probably going to be the ones who will do it, but then what about all the rural folks and all the people who have issues in terms of getting to those places, or it
Right.
will drive more of a wedge, and it will be interesting to see how this evolves. So,
Yeah, I would say like twice yearly though is much more feasible than every 2 months, right? For
sure.
people who might have to travel long distances. Yeah,
Yeah. Okay. Any other
great.
Yeah,
thoughts, comments?
yeah, one other thing, Dan. Hey, it's Laura.
Mhm. Hey.
One thing too is as we expand long-acting injectables, I consider us expert at Owen, but we still have some trials and tribulations of
Mm.
the injection being given in the wrong space, sometimes into the hip joint instead of the ventral gluteal, sometimes, some of the medicine leaking out. And I worry as we expand more that some of the technique may be lost, and I heard of two patients this week that were just getting it from their primary in the community. They thought, oh, wow, this person's on this med. We'll just order it for our clinic too. So something else to consider.
You mean without the proper training on
Without the proper
administration?
training, yeah, just as we expand these to more, and we want to create, yeah, obviously create more access. We want to also make sure that people have the proper training, the proper tracking, because I think we could do a lot of harm and cause more resistance if we're not giving these properly.
I also want to just give a cautionary tale. So I saw a patient in the hospital who had been out of care for probably about like 9 months or so. And he was on lenacapavir and another complicated and some other oral medicines and had gotten himself to undetectable for the first time in his life. But then he also started gaining weight. And so he decided to just disengage from care because he's like, well, I got to undetectable. And now these meds that they put me on has caused me to gain weight and didn't realize that cost him, like access to lenacapavir potentially. And so I think we need to really focus a lot of our outreach efforts on folks, particularly. I mean, thankfully, there's not too many of these folks in our community, but I really think that we need to figure out a way to truly keep them engaged and maybe even, like with Laura, all of Laura's work with, providing care in non-traditional settings, like with a mobile or even home visit type approach. I think we really need to think about, can we do this for those particular participants that just struggle to routinely come into clinic?
It is interesting because like to think about it from a cost perspective, and what I mean is like um, based on individuals, and there's like we're talking about the small cohort of high utilizers with lots of medical expenses related to their kind of complications from untreated HIV and other things. Um, what, how many resources could you put into, supporting and tracking and finding and the person to give twice yearly injectable ART, like how much would that save our health system? Because I think the economics of this are you could spend huge amounts of money on case managers and social workers and really achieve like and have that be very cost effective because the care for these individuals is so expensive.
You could
So
fund
I mean,
a lot of housing with $30,000.
I mean, this is kind of something I'd always thought would be really interesting to engage the health system on, and would utilize a lot of our talent within the division. Uh, but it is like a little bit eerie to say, all right, to name the like 25 people that are taking are costing so many resources to the institution, and developing a project around them specifically. But I think I don't know. I think it's interesting.
Yeah. Well, I think just to kind of follow up on the final comments, Amy Lopes, who works in the private sector, said cost is a huge issue, and I think we just kind of discussed that. Last point from Aaron, we often look at national data and identify priority populations, but regional autonomy and who gets to be first in line for these prevention and treatment options on the community level is probably expensive, but likely more effective use of these new therapies.
I mean, it's cost savings, I would say, in many settings for people that have, adherence challenges. I think these things would be cost savings, but yeah.
Yeah. So thanks, Tim, for an excellent
Yep.
talk. Next week, we have Katie Riggs, who's going to be talking about neuro HIV. And just FYI, I think I was slated perhaps to do the metabolic talk. That's probably going to be tabled for a few months, and I'll probably figure out a date later in the fall. So,
I mentioned
FYI.
lipids once. So
Thanks. That
yeah.
works. All right, everyone have a great weekend. We'll see you next week, hopefully. Thanks.